All right, so our topic here today is about quality management and hospital closures. And one thing that we wanted to do with the Center for Multidirectional Engagement being the international chapter is to kind of start bridging that parallel between Western societies, the US, UK, as well as more East Side. Whereas today we're going to be discussing an article regarding Lebanon and an article regarding rural hospital closures in the US. So the first article, if no one has read it, the links are in the chat box to open and to skim, but I'll just do a very short synopsis. So Article 1 is talking about 1 in 4 rural hospitals closing in the US and how it is such a big impact on the quality of care and the accessibility of care to rural populations as well as underserved populations. Approximated in the past 10 years, 120 rural hospitals have closed, and that has really impacted our nation's most poorest and most vulnerable populations. It ends in kind of speaking about why these hospitals are closing. And one of the studies that they did was a founding factor being that they had not participated in the Medicaid expansion, which lowered their operating margin, and they ended up being in a negative operating margin, decreasing accessibility of healthcare services to these populations. That being said, about 1 in 4 Americans are uninsured or are covered through Medicaid coverage. And so the point of this article is how policymakers really need to ensure that their rural population can be covered through Medicaid, or the risk of hospital closure increases, which just increases our disparity gap. So that being the general synopsis of the articles, I wanted to just open the floor to Giselle, and I'll just start with, what are your first thoughts when you're reading these articles about the quality of care that can be provided between those two healthcare sectors?
Okay, lovely. Thanks so much, Nadia, for the introduction. It has been a pleasure working with you over the last few years, and I'm definitely going to miss you. So I look forward to the discussion some more, and really, guys, huge congratulations for, the ideas coming together, hoping to promote change in the healthcare service, because we know, obviously, healthcare in general is faced with not just an epidemic of nursing shortage, but also resources, which is quite significant. And I think the first thing that occurred to me was, why is healthcare putting these priorities the last thing for government? And when we think about the largest expenditure across any society, it's either in the military or healthcare, yet there's not a lot of prioritization going on. And then this made me reflect on the NHS, the National Health Service, the system that I've worked with for over 13 years. And I mean, obviously, because I'm a nurse, I'm very, I guess, partial and passionate about quite often the disparity with even financial resources that are assigned to giving nurses a raise, which the National Health Service and the government, for that matter, has not prioritized for close to coming up to probably 7-8 years now. So I think that's the first thing that occurred to me. And I was thinking, how can then the onus will primarily then be down to individuals? What's the call to action? How do we mobilize resources? Because ultimately, if we can't trust the government, then clearly there has to be some independent action that occurs. And then my heart really went out to those communities with people who are suffering, because ultimately, you have policymakers, you have the government, but it's the normal people that ultimately gets affected. And I think that just kept resonating with me. What happens to the people of these societies who are left really with very little? And I guess the really challenging thing for me is they have paid their dues. They're probably working, they're contributing to the society, they're paying their taxes. Healthcare is basic expectation, yet they're not even getting that from their government. So I think I was just challenged with these just really basic needs that aren't being met overall.
Giselle, I think you make a very good point in regards to, expediting needed services in crisis situations. I know here in the UAE, we had situations where our main insurance companies approved telehealth as primary visits during this crisis. And I think, I'm not sure if it's still the standard, but that upheld our operating margin here. But what I would like to kind of discuss before we go into our breakout rooms is, assuming we can get telehealth access to more rural communities with different methods of resources and support, how do we maintain that evidence-based practice via telehealth? What was your experience in this situation, maybe given during our COVID crisis here, or what would you recommend in that instance?
No, that's a difficult one. Because as I said, I mean, the dawn of evidence-based practice has been over a few decades, and we still haven't managed to get it from the theory to the practical, to the patient, to that cold face where we need to have the action taken. So there's still a divide between the actual evidence and its implementation. So that's an ongoing struggle. However, we know that there has been a lot that has gone into place. For instance, we know that, I mean, working in healthcare and being at the cold face of the action, no one has time to go and read primary articles, delve into the research, etc. So we do have reputable organizations that have summarized evidence for us to be using at the bedside. And sorry, this comes back to, how do we get those individuals to be called to action? How do we identify them? So one of the things I'm really curious about is, there's a lot of, certainly in the US, I'm not sure how to put this, but I just put it. Let's say there's Bill Gates. He has billions. And quite often you hear him, going to different parts of the world and equipping them. I don't know in what way. I haven't read too deeply into what he does with his altruisms and whatever, but they do have enterprises that help people. So I'm challenged sometimes with, how do these people utilize those funds? And not just him, thinking about all the other really popular, for want of a better word, individuals with resources. How do you tap into those resources? Because they're there. I mean, there are lots of people with resources out there. So I think those individuals, we really need to get them to start listening, so they see where the needs are and really get to equip those people in those communities. And utilizing the World Health Organization resources. And we have lots of other institutes. It slipped me now, but we do have a lot of free online resources available where people can use that information. But another really creative or another way that people will need to start looking at things is, let's say something has been done and the cohort is similar to the work that you are, to the people or the population that you are working with. This is where you can borrow and try small scale, because I think that's the other big problem we have in healthcare. We have something that we want to test and we go large and we think, oh no, it has to cover a whole range of people or else it's not being effective. But we can start small, we can test it. Did it work? So coming back to that evidence, let's start looking at data more. It's like, so I heard an interesting fact the other day. Can you believe that since 1993, all randomized control trials were done only on men? Can you believe that? So then, oh yes, that's a fact. I was shocked. So then they decided that following from 1993, they would stop all trials had to include women. I found that shocking. So that comes back to the challenge of, we have the evidence. Is the evidence actually valuable? So we really have to be creative in looking at the evidence as well, because we still have to interrogate it. It doesn't matter how lovely it looks, we really have to look at it.